Sir, you can start, sir, please.
Your permission to start?
Please, sir. Please, sir.
I have very beautiful line to quote today before beginning, that life is worth living if you love to love, if you do what you like, if you work with pleasure, if you live so that you can leave something behind, if you learn to share and appreciate every moment that you are healthy, free, and alive. This is a beautiful effort of AUSD Delhi branch for living their legacy for mankind. Hello, everyone. Very good evening to all of you. I am Dr. Enenja, moderator here today for the beautiful sessions by two eminent speakers. So welcome you all to Enoch DigiConnect webinar series 1, issue 86. We have two speakers on board today. First speaker is Dr. Rajesh Pasricha. He is the professor and head of department radiotherapy, AIMS Bhopal. And another is well-known personality again, Dr. Rajiv Jain. You all know. So, but before going ahead, I would like to call upon the president of AOE branch, Delhi branch, for a few words before handing over to the first speaker. Dr. Gajendra, please.
Dr. Gajendra could not attend due to some unforeseen circumstances. So I think we can straight away ask Dr. Rajesh Pasricha.
Right, sir. Right, sir. No issue, sir. Yeah, this my pleasant duty to introduce a little bit about Dr. Rajesh. Dr. Rajesh is currently working as a professor and head radiotherapy department at AIIMS Bhopal, looking after the large size department, 4 faculty members and 25 staff members, including medical physics, technologists, and support staff as a team leader and administrator besides routine patient care. He is trained at University Hospital Berlin and Clatterbridge Cancer Center, Liverpool, UK, for the usage of IGRT, respiratory gating, and rapid arc treatments. He is trained for SBRT and proton therapy at Fred Hutchinson's Cancer Center and SCCA, Seattle, USA, under a fellowship by IACA. He has been awarded ISMO Fellowship for Palliative Care for 2017-18 at ISMO Congress, Madrid, in September 2017. He has also been awarded for Astro Technology Transfer Fellowship, US of A and Radiation Oncology in June 2018. He has done the Travel Fellowship, ISMO, Preceptorship course for the lung cancer at Singapore in September 2019. Now, before wasting our time, we should listen more and more from Dr. Rajesh. So, Rajesh sir, over to you.
Good evening, all colleagues and friends, and thank you, Chairperson, for such a kind introduction. Today, I think we will be speaking on the topic of head and neck cancer, which is, I think, one of the most common cancer in our country. And the incidence of this cancer is increasing day by day because as more and more people are using tobacco and smoking and alcohol, and that is why this is the #1 cancer, #1 killer right now in our country as well as also in the world. So without wasting my time, I will start sharing the screen. I think I suppose my slides are visible. So can I, with the permission of Chairperson, can I start, sir?
Yes, sir. Please, sir.
Uh, so today we will be discussing the general management of locally advanced head and neck cancer and what are the methods, especially the systemic treatment, that is the like radiotherapy and surgery. We all know there are local treatments for cancer. Systemic treatment, basically the drugs and the chemotherapy drugs which we give. So what are the newer advances by which we can add these drugs to the radiotherapy and surgery and improve the responses and the treatment outcomes? So, as I will start with the, I think I'm not able to move the slide. I will again, I think I will start again. The slides are, I suppose the slides are moving. Sir.
Yes, sir. Slide is okay, sir.
So,
You have to.
yes, sir. As yes, sir.
Yes, sir.
As okay, sir. I suppose I'm audible also along with the slides. So, head and neck cancer is one of the leading cause of death in cancer, cancer-related deaths. It is the fifth leading cancer in US, and it is the first leading cause, first common cancer in India. In India, around 30 to 40% of all the cancer, they are all head and neck cancers. Because of the food, lifestyle and food habits in India, a lot of people using tobacco, gutka, smoking, BD smoking, and all that. Because of that, the majority of the cancer in Indian subcontinent is head and neck cancer, which includes all the sites like oral cancers, laryngeal cancers, and
Excuse me, Dr. Rajesh, you will have
yes.
to have full screen in the presentation.
I suppose it is
It's not full screen at the moment.
I have done the full screen. I think let me.
It's not showing on the screen on Zoom.
Okay, let me.
If you go to the screen show, slide show,
Yeah,
the
yeah,
bottom right.
I did that, but let me.
No, but it's still not.
Sir, can I share on your behalf, sir? Can I share?
Okay, just let me try this. So we had this problem earlier in the diagram also.
Okay.
Is it okay now?
Yes, now it's fine. Wonderful. Go ahead.
As I'm told that it is the most common cancer, and 30 to 40% of all the cancers in India are head and neck cancers. So people having age more than 50 are more susceptible to it. And nowadays, other than the alcohol and tobacco, one new risk factor is emerging, that is the HPV virus, because of which it is one of the main causes of head and neck cancer, especially in the Western countries. Although the HPV-related head and neck cancers, they are comparatively less aggressive as compared to the non-HPV-related cancers. 90% of the cancers of head and neck, they are all squamous cell carcinomas, and if they are detected early, especially in the stage 1 and 2, around more than 80% are curable. But in our country, most of the people, they present late in advanced stages where the survival decreases to less than 40%. I think you have to start the slides from your end. It is not running in the full screen from there. Can I just request the organizers to start sharing the slide from there, and because again full screen.
Okay, sir. I'm sharing. Okay.
Yeah, next slide, please. So when a patient comes to us with the complaints of tumor or the complaints of ulcer in the mouth or hoarseness of voice, a diagnosis of cancer is made by biopsy. You all are aware by we have to do a biopsy, and after the biopsy, get the confirmation of cancer. You have to do a CT neck, chest X-ray, and if possible, a triple endoscopy to map the location of tumor and the extent of tumor. Nowadays, PET scans are available to see whether the disease is spread to the distant organs or not. Usually, the rate of spread in advanced cancers is 5 to 10%. So, if possible, a PET scan can be done to rule out the distant spread. And if it is a distant spread, then stage 4 and the treatment is only chemotherapy and the systemic treatment. Next slide, please. As per the NCCN guidelines, NCCN guidelines are the guidelines formed by the US Society of Cancer, and these are the guidelines which are reviewed and every quarterly in the year, and as the new evidence comes in, they keep on revising these guidelines. And so, as per the NCCN guideline, that is the National Comprehensive Cancer Network in US. So these are the guidelines which we all follow. Most of us they follow in India and all over the world. The treatment of locally advanced cancer is concurrent chemoradiotherapy. That is, you start radiotherapy and add some form of systemic treatment in form of chemotherapy, either weekly dose or maybe a 3-weekly dose. And this is the preferred mode of treatment if surgery is not possible. Like in early stages, it is surgical treatment or it is the radiotherapy. But in advanced stages, it is the only chemotherapy and radiation therapy concurrently given is the treatment of choice. So next slide, please. As you can see, next slide. So as I've earlier discussed, that stage 1 and 2, the prognosis is very good. Around 60 to 80% of patients are cured completely of the disease. In fact, here the more risk is of second primary. Second primary, usually second tumor because of the radiation or because of the field cancerization. These cancers you usually see after 50 to 20 years of treatment. Since the patients are surviving long, so this is the one of the major problem which we see in these kind of patients if patients are cured. And while in stage 3 and 4, like 40 to 80% people there, they recur locally, and around 10 to 30% also patient develop metastasis. And the cure rate overall, as I've told earlier, is less than 40%. Next slide, please. So this is the overall chart which is showing how much is the survival in each of the stage and how much cases we get. Early stage we get only 15% to 20% cases in stage 1 and 2, but the survival is very high, ranging between 85 to 70%. While in stage 3, bulk patient which we get are of stage 3, 4 or unresectable cases, and again the survival falls below on an average around 40%, 55% in stage 3 and less than 10% in patient which are very advanced. Next slide, please. So now, as we have seen, we can give radiation and chemotherapy or the systemic treatment concurrently side by side. So we will see a little bit what evidence is available to us for adding chemoradiotherapy. So if we look the trials before 1990, this kind of treatment of giving chemotherapy with radiation, it was based upon all the clinical trial results, and most of the trials they were done in 1990s or before that. In that they showed that adding chemotherapy or the systemic treatment to the radiotherapy, it increases the local regional control of tumor as well as the survival. But since we are adding to treatment, it has a cost in form of toxicity, which can be acute toxicity, which we see during treatment. Also, when the treatment is complete, the acute toxicity is gone, but there are certain long-term side effects which are seen in the patients, and these are in form of late toxicities. So there was, although since patients are results are good, and there is organ preservation can also be done by avoiding the surgery with the use of chemotherapy and radiotherapy. There is and the benefit is seen across the sites in the head and neck, whether it is oropharynx, nasopharynx, or the larynx. And also, when it is also seen that there are certain trials, if the local control is better, the distant metastasis also decreases. So all these results were available to us from the trials which were done in early 90s and the late 90s. Next slide, please. So in the start of early 2000 and 2009, it was shown that chemo radiation is superior, especially in the post-op setting. Also in early stage when the surgery is possible, you can add adjuvant radiotherapy and chemotherapy. There are specific indications for that. You can add and improve the long-term controls in those patients also. Then there were new drugs coming in picture, like which are, as we will go ahead in the presentation, we will see, which are the monoclonal antibodies, and cetuximab was one of the earlier monoclonal antibodies which was available in the market. So it also added with radiation improved the local regional control and survival. Then the new drugs, other systemic chemotherapy drugs like taxane, they came into picture. And also it was seen that if they are given before starting of radiation, that is in the neoadjuvant approach, so that the tumor shrinks with the chemotherapy and then you can add radiation later on. That also has some benefit in advanced cases. So all the randomized trials were done to show there are at least 2 major randomized trials which shows that if you add chemotherapy with taxanes before starting of radiotherapy in neoadjuvant setting, which is known in neoadjuvant setting, it increases the progression-free survival and also some overall survival in some patients. And also the role of HPV, that is HPV virus as a tumor marker of outcome, as I've told earlier, that the HPV associated tumor, they have generally good prognosis. So that thing also came into the picture in between the years 2000 2009. Next slide, please. So finally, there was one large meta-analysis which was published in 1993, and there's a update also which we will see. It was a combined meta-analysis of 63 randomized trials. And this was I will say, the best available evidence which showed us that the addition of chemotherapy to radiotherapy improves survival, and it should be the preferred mode of treatment. As you can see that in the chart also, out of adjuvant treatment, that is the adjuvant chemotherapy, that is treatment, chemotherapy treatment which we give after radiation, induction chemotherapy, the treatment given before radiation, and concomitant, that is a treatment, chemotherapy treatment given with radiation. Out of all these three, the concomitant treatment, that is chemotherapy given along with radiation, is the best. And the absolute benefit is around 8% as compared to 1 or 2% benefit of giving chemotherapy before or after completion of radiotherapy. So this thing almost now sealed the fact that chemotherapy should be given with the radiotherapy if you want to improve the results in head and neck cancers. Next slide, please. And all again, in 2009, they published an update analysis by adding the newer evidences. McKinsey group again published this thing, and again, this was also proven after a gap of around, I think, from 93, they published again in 2009. So the benefit was persistent. It was again shown in the update also, and especially although the benefit was less in older patients like the 70-year-old patient, because then that kind of patient, they tolerate chemotherapy a little poorly as compared to younger patient. But overall, the 8% benefit shown in earlier version of the study, it persisted after, say, also when they published again the update of this study in 2009. So next slide, please. So now we know that chemotherapy and radiation given side by side, concomitantly, is the best available treatment right now. But there are, as I've told, there's a cost to pay. Cost not in terms of money, but in terms of the side effects. So it improves the loco-regional control. And it facilitates organ preservation because we are able to preserve the organ and make it free from cancer. And there is also improvement in survival. But at the same time, the side effect, acute side effect, most common side effect is the mucositis, which we see in patients when we give radiotherapy. It doubles the rate of acute mucositis. Patient will come and tell कि मेरे मुंह में छाले हो गए, and then he will not be able to eat anything for that time period of time. You have to tell him that no, this is very important, and then you tell him that you please come on the liquid diet, come on the soft diet. So it becomes very, very difficult. Plus the acute mucositis, again, it is a site for infections also. Lot of fungal infections come into the picture if you don't take care of the mucositis in a proper manner. So, but again, mucositis again based on the stage. If it is a large disease, you are giving radiation in a large area, so mucositis will be more. And also the long-term, there can be long-term functional defects in the speech, swallowing, and mobility of the organs, like mobility of the jaw, because the fibrosis sets in. And if you don't train the patient for physiotherapy and to take care of the organ after the completion of treatment, again, there are some long-term effects. Although with the proper guidance and proper physiotherapy, the long-term side effects are minimal. But yeah, they are there, and these are increased when you add the two treatments in form of radiation and chemotherapy. So the next slide, please. So as I've told, like there are other side effects like long-term dysphagia, and the saliva becomes thicker, and there is difficulty of swallowing. All these things, they persist. Although the patient is cured of tumor, but all these factors persist, and they affect the quality of life in a very bad manner. And patients do come and tell us that, okay, we have cured of cancer, but now what to do? And there's loss of taste, and there's dryness of mouth, and they are all long-term side effects. So although there are some methods now available to tackle the long-term side effects, but yes, there is there are a lot of side effects if you add two form of treatment together for improving the controls and for improving the survival. So next slide, please. This is one of the picture. You can see that diaphragm is swollen during radiotherapy, and there is some fungal infection also. So this is very, very common for us to see these kind of patients during treatment. Next slide, please. So what is the method to decrease it? One method is you improve the radiotherapy, whatever the newer form of radiation are coming, like IGRT and proton therapy, for which I took training outside India. So they are all methods to decrease the side effect of radiation. What these new forms of therapy, radiation therapy does is that they will focus the radiation only on the tumor. And during treatment also, it is made sure that the radiation doesn't go here and there. And during treatment also, imaging and all is done, and then continuously check is kept on the doses of radiation also during treatment with the help of all computerized treatment. So nowadays radiation therapy has become safe, and the normal tissues which is surrounding the tumor, they are all excluded from the field of radiotherapy. So this is one way of decreasing the side effects of radiation, and then definitely we do get lesser side effect nowadays as compared to the earlier days. When I was a student, and when I started radiotherapy. In last 10 years, the radiation therapy has almost undergone a dramatic change. So same is true for the systemic treatment in chemotherapy also. The newer drug have come like in form of docetaxel and in form of induction treatment, we can give these drugs. Now from last 5 to 7 years, the monoclonal antibodies, that is the antibodies against the epidermal growth factor receptor EGFR, which is a receptor which is highly expressed in the tumor as compared to the normal tissue. So when we give these drugs, they go and bind only to the tumor. Preferentially, they bind to the tumor as compared to the normal tissue. And at the same time, we are giving radiation also, they add to the effect of radiation. But the side effects are less because these drugs, they don't usually, or they add to the normal, they bind to the normal tissue to a very lower extent as compared to tumor. So you can give intratumoral injections of the drug also. Again, it is a very cumbersome method, so it's not very popular to give the intratumoral injections of chemotherapy drugs to decrease the side effect. And there are other gene therapy things, some gene therapy drugs are coming into the play. But again, they are all till now not established their relevance in the clinical field. And again, immunotherapy is the latest buzzword in cancer treatment. Again, immunotherapy has established its role till now only in the recurrent setting after in the second line as a third line treatment. Still, it is not a first line treatment, and again, it is very costly. So, of all these options, the monoclonal antibodies are the only newer option which are right now competing with chemotherapy, either alone or along in combination, which we have to decrease the side effect and to improve the controls. So next slide, please. Next slide, please. So now we will discuss this today's topic, which is the topic for the improvement of systemic therapy for improving the control rates. So as I've enumerated in the earlier slide, that gene therapy is still under research. Immunotherapy is not as a first-line treatment. It is only monoclonal antibodies or the mAbs commonly used. They are right now as established treatment as compared to chemotherapy for improving the local control as well as decreasing the side effects. There are two main mAbs available to us right now for the users. That one is cetuximab and another is the nimotuzumab. Cetuximab is marketed by a multinational company, while nimotuzumab is commonly known as Biomab. The drug has been developed and researched by an Indian company. It's an Indian product, and it is much better in terms of decreasing the side effect and comparable in terms of response rates, as we will see in the upcoming slides. Next slide, please. So a little bit about the EGFR expression. It is the epidermal growth factor receptor. This receptor is highly expressed in that almost a lot of tumors, especially in the head and neck cancers, lung cancers, and colorectal cancers. This is a growth factor receptor. Since it is highly expressed, that is why it causes tumor to grow very fast. And all the histopathological and the immunohistochemistry and molecular studies which has been done, they show that around up to it is so common in head and neck that you don't even need to test it, because it is seen in almost all studies. It has shown that it is overexpressed in around 95 to 100% of the tumors. And in the second number comes with the lung cancer. Lung cancer also it is expressed in around 80% of tumors. And same is true for the colorectal also. These are the tumors where the growth factor receptor is highly expressed, preferentially in tumor as compared to the normal tissues. And that is why one of the strategy to control the growth is to block these receptors with the help of monoclonal antibodies, which are now available in form of cetuximab and the Biomab. Next slide, please. So one of the earlier studies which was done in 2000 to show its efficacy of cetuximab in conjunction with the radiotherapy was done. And it was a phase 3 study, which is, I think, highest form of, we all know is the highest form of evidence in medicine. That is a randomized control trial. It was done in 2000. In this trial, there were two arms. In one arm, they gave only radiotherapy. In another arm, they added radiotherapy to and cetuximab. And then it was done in form like first dose was loading dose, and then they gave weekly cetuximab along with radiotherapy for around 8 weeks. And then what happened? Next slide, please. And then, as you can see from the graph, addition of cetuximab to radiotherapy as compared to radiotherapy alone, it improved the control rate. And 5-year survival jumped from 36% with radiotherapy alone to 46%. There was 10% improvement in the survival of patients when they added cetuximab to the radiotherapy. But again, here you can say that earlier I was telling that chemotherapy plus radiotherapy is the standard treatment. Here we are comparing only radiotherapy with cetuximab plus radiotherapy. What will happen if we add cetuximab to radiotherapy, chemotherapy, and cetuximab? Will it improve the control? Theoretically, it should improve because chemotherapy and radiation is a standard treatment. Here, one of the arm is not standard treatment. To answer this question, RTOG, that is the radiotherapy group, they did a control trial in 2014. Next slide, please. We will see this now. We will look into this. They randomized around 940 patients into two arms. One arm of the trial was only radiotherapy plus cisplatin, which is a standard treatment which usually we give, and another arm was radiotherapy, cisplatin, and cetuximab. And intuitively, this arm should be better. But surprise, as we will see, it was a surprise to all of us when the result came. Next slide, please. No improvement at all with addition of chemotherapy to and radiotherapy and cetuximab. It was as good and as bad as adding only chemotherapy to radiation. So this monoclonal antibody almost failed this trial of. Some people said that because all the systemic disease has been taken care by the chemotherapy, so there's nothing left for the EGFR to act upon that remaining disease. So whatever may be the reason, here it is very clear that adding extra treatment to a standard treatment is not useful, which goes against the common sense. Like adding cetuximab to radiotherapy, chemotherapy has not led to any benefit. Except there was some small subgroup where it showed slight benefit. That was when P16, which is a surrogate marker for EGFR receptors. In that group, it showed slight improvement in the local control. But again, it is the P16 testing is done by using the IHC. But when you do a genetic testing of EGFR as a molecular marker, then this benefit was also lost. So next slide, please. And there was a cost to pay to add cetuximab to again like chemotherapy. A lot of reactions were seen in the skin, even grade 3 reactions, that is the necrosis of skin, was also seen in around 10% of the patient. The rash started as acneiform rash, and gradually as the radiation progresses, if the rash progresses to a very bad state and it can even spread to the outside of the radiation area, to chest, hand, feet. And again, because of this, a lot of infection happen in the skin. And also along with that, a lot of cardiotoxicity was seen with this drug. Although it was less than 5%, but again, it was one of the concerns. And hypersensitivity reaction, 3 to 5%. So this drug was, although anti-EGFR and specific to a receptor, still a lot of reactions were seen. And people said that if you see more reaction, that means the response to the tumor will also be good. So this is how the company tried to give an explanation for increasing the skin reaction and other things. But we used this drug initially quite a lot with radiotherapy, and a lot of skin problems we used to see during radiotherapy. So it is a kind of decreasing one toxicity and adding another one. So, but this was the option available to us in early 2000, 2005, 2006. Next slide, please. So, based upon this evidence of phase 3 trial, the NCCN guideline, they recommended cetuximab as an optional treatment in certain situations when there are contraindications for use of chemotherapy and radiotherapy. In that setting, you may use this drug, but it is not a preferred treatment, and it cannot replace the chemotherapy and radiation therapy based upon whatever evidence we have. So, as you can see, the recommendation is there, but it is a kind of secondary drug In certain circumstances, you can use where you are not adding cisplatin or other chemotherapy drugs with radiation. Next slide, please. Here comes in the picture the another drug, that is nimotuzumab. This was developed in India itself, and it is a humanized IgG type of monoclonal antibody against EGFR. So, what is the difference between the nimotuzumab and cetuximab? Cetuximab is basically a partial humanized antibody. Half of the part of the antibody is it is known as chimeric antibody. Half part of the antibody is from the mouse, and half of the part is from the humanized. But nimotuzumab is totally humanized antibody, and it was developed against the EGFR in India itself. Next slide, please. Next slide, please. So it has got a very unique safety profile as compared to cetuximab, and the reason probably is that it has got very high strong binding to the tumor cells as compared to the normal cells. But in cetuximab, it was seen that it binds very strongly to tumor as well as the normal tissue also. So next slide, please. So since it binds very low to the normal tissue, the side effects of skin are usually eliminated, or they are very minimal with use of this drug, nimotuzumab, as compared to cetuximab. Next slide, please. So they did a phase 2 trial kind of thing to establish its efficacy and safety, which is, as we all know, drugs are tested in phase 2 trial and then phase 3 trial. So phase 2 trial, which was published in 2005, the company did the safety trial. Pardon? So this was there were two groups in this trial. One group had biomab added to the chemoradiotherapy arm, and another had biomab added to only RT arm, and both arm had patients which were on RT as well as only on the CT chemoradiotherapy. So this was a kind of 2x2 design of the trial, and this the result we will see in the next slide. Next slide, please. Next slide. Next slide. The primary endpoint of this study was to establish the safety and efficacy when the drug was given with chemoradiotherapy or with radiotherapy alone. And secondary endpoints were progression-free survival, overall survival, and and also the disease-free survival. Next slide, please. And as you will see from the graph, the patient in which the EGFR antibody, that is nimotuzumab, added with during chemoradiotherapy, that is concurrent chemoradiotherapy, or in the second graph when it was added to only to RT, the response rates were very much better. Also, the PFS endpoint was better. Like you can see with CTRT, the median survival was 21.3 months, and it was not achieved. That is, the people were still surviving, and median was not achieved in the chemoradiotherapy arm. And same was true for the only radiotherapy arm. In only radiotherapy arm, the people who get only radiotherapy, the survival was around 7 months, 36 to 9 months. And the people who got radiotherapy and biomap, the survival jumped to 20 months. So there was a huge difference in the response if you add biomap to the radiotherapy or to the chemoradiotherapy, as opposed to cetuximab, where the benefit was seen only when you add cetuximab to radiotherapy, and there was no benefit when you added cetuximab to radiotherapy plus chemotherapy. So next slide, please. Since a clue was given to us that biomap will work if you add it with radiotherapy and chemotherapy as against cetuximab. To test this hypothesis, Tata Memorial Hospital in India, they did a randomized trial by Kumar Prabhash et al. And it was a phase 3 trial where they added nimotuzumab to the cisplatin chemotherapy and radiotherapy as compared to chemotherapy and radiotherapy alone. The trial design is almost similar to the RTOG trial in which they tested the cetuximab. Next slide, please. So all the patients from stage 3, 4 were taken, and all the sites of head and neck like oropharynx, larynx, hypopharynx, and oral cavity were taken, and all the patients had the good KPS. And again, the group all patients were divided to two groups, in which in one group they gave only cisplatin and radiotherapy. In the other group they gave radiotherapy, cisplatin, and they added the nimotuzumab, that is the monoclonal antibody. And then let us see what happened in the results. Next slide, please. Next slide. So if you look at now, these are the results, and as we saw in the phase 2 trial, there was a benefit of adding nimotuzumab to the chemoradiotherapy arm, that is the standard treatment arm. and there was a benefit of around 5%, around 3% in the progression-free survival, 50% survival, 50% progression-free survival in the chemoradiotherapy arm, which down to around 62% with the nivolumab and the chemoradiotherapy arm. Next slide, please. And the same benefit was seen in the overall survival. The patients who received nivolumab, the 2-year overall survival was around 64%, as compared to the arm which did not receive nivolumab, where it was only 57.7%, and it was the p-value was significant in this case. Although p-value was not significant, but there was a survival difference, and I think it's only a 2-year overall data, and 5-year results are still awaited. Next slide, please. So if you look at both the trial, both the drugs, if you compare the trials of RTOG, where they added cetuximab to chemoradiotherapy, as compared to Tata Memorial trial, where they added nivolumab to the chemoradiotherapy. Here we can see that there is some benefit in the progression-free survival with the addition of nivolumab, but there is no benefit with the addition of cetuximab. At the same time, the patients in India, they are mostly HPV negative. And in this trial, which was done in Tata Memorial, the mostly patients were 89% were negative of HPV, which means they were having aggressive disease, as compared to the trial which was done in the US, where it was 73% patient had positive HPV. So that is, their trial had the patient who had a better prognostic disease. So if you can see the benefit in progression-free survival, where the disease is aggressive with this drug, as compared to no benefit where the disease is lesser aggressive in the RTOG trial. So I think the drug does hold some merit. Next slide, please. And this is also visible from the this graph, which you can see there is a forest plot, which is a statistical representation of all the parameters which were there in the trial. It also shows the fact which I just enumerated. Next slide, please. So based upon the evidence which is available to us, the Indian ICMR, they have published along with all the oncologists, they have published the Indian clinical practice guidelines as opposed to US guidelines, which only recommend cetuximab, that too only in the certain situation. So we have our own guideline which were published in Indian Journal of Cancer. So as per these guidelines, next slide, please. Next slide. So you can see the treatment for the locally advanced cancer, you can add nivolumab to the concurrent chemoradiotherapy, especially if patients are HPV negative or positive. In fact, the benefit is more in the HPV negative. So otherwise, in early stage cancers, the treatment is only chemoradiotherapy. Next, this is for the oropharyngeal site. Next slide, please. Next slide, please. And there was some animation to highlight that. Also in the hypopharynx subsite. If you next slide, please. Next. So the benefit of adding nivolumab is persistent in the hypopharynx also, because in that trial they have included all the subsites of head and neck. Next slide, please. And same is true for the laryngeal cancer also. Nivolumab in Indian guidelines, they recommend we should add nivolumab to the concurrent chemoradiotherapy if patient has a locally advanced disease. Next slide. Yeah. So the take-home message that the nivolumab is in combination with cisplatin and radiotherapy, which is a standard treatment for advanced head and neck cancers, is proven to be superior to cisplatin and radiotherapy alone for improving the progression-free survival, time to local control, and the disease-free survival. Overall survival, still the results are awaited because it's only 2 years since the trial was completed. Probably in the time to come, we will see the overall survival benefit also in the drug. This combination provides an alternative therapeutic option to us, to all the oncologists, to improve the response and the treatment results in the locally advanced head and neck cancer. At the same time, decreasing the toxicity also, because the toxicity of radiotherapy and cisplatin is substantial. And we should have, and this is one of the newer alternative available to us right now, with which we can improve the response of the treatment and at the same time decrease the toxicity also. Next slide, please. I think I thank again to the organizers and to for giving me this opportunity to present this topic. And I will be very happy to take if there are any questions, please.
Thank you very much, sir, for excellent presentations. Now I may request audience to, if you have any questions. So far, I do not see any questions sent to me, but if somebody has something, they can come forward. They can ask you questions.
Yes, Dr. Rajesh, excellent presentation on one of the most important cancers in mankind, especially in India.
Thank you so much.
I just wanted to know, since you are from AIIMS Bhopal, and that's a very important area from the point of view of tobacco chewing.
Yes, sir. Yes, sir. You are correct, sir.
I just wanted to know what is the prevalence and how much load that you have in AIIMS Bhopal of head and neck cancer, number one. Number two, what are the facilities available in AIIMS Bhopal? And is this therapy available and how much does it cost? Like cisplatin along with radiotherapy, is it available in AIIMS Bhopal? I would like to know these. Thank you.
Sir. Sir, in fact, when I came here and my director also told me that this is I will say, the home of oral cancers in India because of a lot of tobacco chewing. And that is true. We see around 50% of our all caseload is head and neck cancer, especially the oral cancers. And they all come with such a large growth that it becomes very difficult to treat them. Luckily, we have all the facilities in the institute. That is the modern form of radiotherapy, that is IGRT and IMRT. And from last 2 years, we are fully operational. And chemotherapy cisplatin is also very easily available. This is one of the basic drugs now in the oncology. In fact, the newer drugs like nimetuzumab and cetuximab, they are a bit costly, but there is a huge cost difference of cetuximab and nimetuzumab. Cetuximab costs around 80,000 per cycle, while nimetuzumab is around 35,000. And there is some incentive given from the company also because this is an Indian drug. And in fact, one of the things I like to highlight here is that after Ayushman scheme, all this, even cetuximab still we cannot cover under Ayushman, but the nimetuzumab drug can be covered under Ayushman also. So most of the people we are able to give this drug also along with the standard treatment of radiotherapy, which is free under Ayushman, and cisplatin, which is also free. So we save some cost there and we try to use this new drug along with the radiotherapy. That is what we are doing right now.
That's wonderful to know that AIIMS Bhopal is doing such a great work, making the real access to cancer care in the place where it is actually needed.
Yes, sir. Yes. Thank you, sir.
Thank you so much.
Thank you, Dr. Rajesh, for excellent answers, smart answers. Any other answer? Any other questions from anybody now? I don't think there is a question now. So thank you, sir.
Thank you so
I think
much.
we should go to the next speaker now. Dr. Rajiv Jain, sir, doesn't need any introduction. However, it's my duty to moderate session, so I feel very nice to talk about Rajiv sir. Although I'm not in Delhi, but somehow I know him personally. So all the issues in all the series, all the as a speaker, he's excellent as speaker. So today, as such, he used to speak at many occasions, and wherever he volunteered himself to speak, wherever he get chance, in simple words. So he's so passionate for teaching people. So today he has taken we have requested him for Epid updates, epidemiological updates, COVID-19. Little about Rajesh, Dr. Rajiv sir. He is a senior consultant Health Indian Railways New Delhi. He's like 40 years. He has 40 years of experience in health and hospital administration. He has done he has got the fellowship award of Indian Public Health Association, then fellow award of Association of Environment and Occupational Health Delhi, then published and presented more than 145 scientific papers in national and international conferences, journals, and books. Sir has the fellowship, a scholarship by World Health Organizations, WHO, National Institute of Health, NIH, US, then Canadian Society for International Health, CSIH, International Clinical Epidemiology Network, INCLEN, and International Society for Priorities in Healthcare. So better we should learn from him. Dr. Rajiv, sir, please take over now.
Thank you, Dr. Jha, for the nice words spoken.
Thank you, sir. Thank you, sir.
The Saturday evening, we take a stock of the evolution of COVID-19 pandemic in the world and in our district, in our country, in our region. And this Saturday, we will again take a stock of the epidemiological situation of COVID-19. How unpredictable the pandemic has been, it would be evident from the data that we see today. And it's affecting the entire world. And it's been, who could imagine that 2 years would pass and we will still be facing a catastrophe of COVID-19 pandemic all over the world. Country after country is rolling with Omicron invasion. So at this stage, I would like to take you to the World Health Organization, a small video capsule where the DG WHO and the scientific experts of World Health Organization will share with you their insights into the current stage of the pandemic of COVID-19. Let's listen to them first before we proceed further.
Welcoming you to our first global press conference for
to end the acute stage of the pandemic, the highly effective tools science has given us need to be shared fairly and quickly with all countries of the world. Vaccine inequity and health inequity overall were the biggest failures of last year. While some countries have had enough personal protective equipment, tests, and vaccines to stockpile throughout this pandemic, many countries do not have enough to meet basic baseline needs or modest targets which no rich country would have been satisfied with. Vaccine inequity is a killer of people and jobs, and it undermines a global economic recovery.
19 and other health emergencies. Today,
last week, the highest number of COVID-19 cases were reported so far in the pandemic. And we know for certain that this is an underestimate of cases because reported numbers do not reflect the backlog of testing around the holidays, the number of positive self-tests not registered, and burdened surveillance systems that miss cases around the world. While Omicron does appear to be less severe compared to Delta, especially in those vaccinated, it does not mean it should be categorized as mild.
Tedros, we also have in the room Dr. Mike Ryan.
Just like previous variants, Omicron is hospitalizing people and it's killing people. In fact, the tsunami of cases is so huge and quick that it is overwhelming health systems around the world. Hospitals are becoming overcrowded and understaffed. which further results in preventable deaths from not only COVID-19, but other diseases and injuries where patients cannot receive timely care. First-generation vaccines may not stop all infections and transmission, but they remain highly effective in reducing hospitalization and death from this virus.
Of people who've been infected to go into quarantine.
Having the contacts of confirmed cases being put in quarantine or quarantining at home is really critical to prevent the onward spread. Now we know that that is very difficult to do. We know that that takes effort. People need to be able to not work and be supported in not work, be supported in quarantine to make sure that they can provide for their family, that they have food, et cetera, et cetera. And that is not a small matter.
Body actually needs to do it.
For every day you reduce the quarantine, a small proportion of people will go on to develop symptoms and potentially affect others. But you could say that's 14 days or 40 days, and you can go into a very long period. So this is a trade-off. The science gives you a range, and that range peaks, I think, at about 5 or 6 days, and then falls off exponentially. So based on a country's need, based on the economy, based on the availability of teachers, health workers, and others, based on the availability of tests, countries have flexibility within that to set the periods of quarantine that meet their goals. And I think
Dr. Bruce Aylward, Senior Advisor to the Director General.
In Ethiopia, WHO was able to dispatch 14 metric tons of medical supplies to Afar and 70 metric tons to Amhara in December. 2 places have been affected by the conflict. In Tigray, WHO has not been permitted to deliver medical supplies since mid-July of last year. This is despite repeated requests from WHO to provide medical supplies to Tigray region, which would help meet some of the humanitarian and health needs in Tigray. Even in the toughest periods of conflict in Syria, South Sudan, Yemen, and others, WHO and partners have had access to save lives. However, in Tigray, the de facto blockade is preventing access to humanitarian supplies, which is killing people.
Questions. I know there were many more of you with hands up, and I
So you know now where the pandemic is. It's a serious situation, and the pandemic is very much there all across the world. So let's take the stock of the situation as on date. Next slide, please. Well, there are information worth noting. 1.5 billion doses and counting. India's COVID-19 vaccination drive reached a major milestone on Friday, as the total number of vaccine shots administered across the country crossed 1.5 billion. The landmark comes at a time when the third wave of the pandemic has started taking hold across the country. A look at the numbers behind the vaccination drive. Less than a year of vaccination and 1.5 billion shots administered till Friday evening. Of the over 1.5 billion doses administered since the beginning of the COVID-19 vaccination program, nearly 879 million have been first doses, while the remaining 627 million shots have been second doses. These doses have been administered to 873 million people so far. In total, 9 in 10 of India's adults have now received at least one shot. 66.4% are fully vaccinated, while another 26.5% are partially vaccinated. In terms of age groups, around 95% of those between 45 years and 60 years have now received at least one shot of the vaccine. The corresponding number for the 60 plus age group is 89%, while it is around 86% for those between ages 19 and 45. That is what the data is showing. The daily rate of vaccination, however, has been heavily fluctuating. At times, it has soared to averaging more than 10 million doses a day, and other times it has dropped to 1.4 million shots a day. Despite dropping to under 3 million doses a day in early October, the drive has again picked up pace in recent days. In the past week, more than 7.5 million doses have been administered every day on average. Coverage among adults, as you are seeing on the graph in the data, is very reflective. The rapid pace of coverage for the 15 to 18 age group, 27% of India's eligible teenagers have received their first shot. This high demand for vaccines among eligible teenagers, that is those between 15 to 18 years old age group, means that over 4 million doses have been delivered to this age group every day up to January 6, and 3.2 million had been delivered up to 6 p.m. on January 7. Means that 5% to 6% of this age group has been vaccinated every day since January 3. More than a quarter of them have now received their first shot. To be sure, this coverage is not uniform across Indian states. Of the 23 regions, the northeastern states other than Assam are clubbed together, for which population projections are available from the National Commission on Population. 11 had covered eligible teenagers more than the national average, with states like Andhra Pradesh and Himachal Pradesh covering almost 70% of the age group. Punjab, which has covered only 1.7% of the age group, and almost all eastern states, on the other hand, have not covered even 20% of the age group. So this disparity, this inequity needs to be addressed. Next slide, please. Yes, this is important to understand. Delhi is charting now the 5th COVID-19 wave. Cases in the city have increased rapidly for over 2 weeks now, but hospitalizations continue to stay low and grow at a much lower rate. Today, Delhi reported more than 20,000 cases in the last 24 hours. Next slide, please. Another issue is the curbs that have come out, and it's very difficult to keep pace with the information and the changes that are made in the curbs due to COVID-19. What is allowed and what is not allowed is a very tricky job for a common man. But look at the way the curbs are prevalent in Delhi. A weekend curfew is being implemented in Delhi. It is imposed from January 7, that is Friday, till 5 a.m. January 10, that is Monday. Only people engaged in essential services will be allowed to commute, apart from some other relaxations with valid ID cards or curfew passes under special circumstances. An existing night curfew is already in place in Delhi from 10 p.m. to 5 a.m. But if you do not follow this order, then under the provision of Section 51 to 60 of the Disaster Management Act 2005, Section 1 and 88 of the Indian Penal Code, and other applicable laws, you can be punishable. What essential services are allowed in Delhi now? Shops dealing with foods, groceries, fruits and vegetables, dairy, milk, foods, meat and fish, animal fodder, pharmaceuticals, medicines and medical equipment, banks, insurance offices and ATMs, print and electronic media, telecommunication, internet services, broadcasting and cable services, IT and IT-enabled services will be open. Delivery of all essential goods, including foods, pharmaceuticals, medical equipment through e-commerce is allowed. Those providing essential services will need to produce e-passes or valid ID cards. There are restrictions on gatherings and outing, markets and restaurants, healthcare and emergencies, household needs, and travel. So there is a need for every citizen of the country to understand what is allowed at what place and on what day of the week, and accordingly plan his life. It's a difficult choice, but it is essential to contain the pandemic. Next slide, please. Well, this week we had new guidelines for COVID patients. The new measures are keeping in mind that milder case outcomes don't complicate efforts to maintain a balance between containment and avoiding disruption of daily life. Home isolation period has been reduced from 10 days to 7 days. This is in line with the steps taken by UK and US, where isolation periods have been cut in light of milder infections caused by the Omicron variant. People who end isolation at 7 days should continue wearing masks when they go out. Home isolation is not recommended for those with compromised immunity, like HIV infected people transplant recipients and cancer patients. Only after doctor's evaluation for people above 60 and with comorbid conditions like diabetes, heart disease, and chronic lung or liver disease. When to test? Asymptomatic close contacts of COVID positive cases need not get tested, but should stay at home. When to seek medical help? 100 °F plus fever for more than 3 days, difficulty in breathing, SpO2 less than 93% on room air, chest pain, or confusion or fatigue. For family caregivers, among the other changes, the center also asked for requisite facilities at home for other family contacts to be able to quarantine and for caregiver to be fully vaccinated. Next slide, please. Home isolation for care of COVID-19. AIMS New Delhi has given revised guidelines for care of COVID and COVID suspect patients. Show 7 days quarantine for asymptomatic contacts. For symptomatic patients, isolation for at least 7 days since testing positive and no fever for 3 days. What symptoms appear in what condition? Omicron has more common cough, sore throat, fever, tiredness, headache, aches and pains. Has no sneezing or very rare diarrhea or very rare runny nose. While this same thing is more common, runny nose is more common in common cold, and if you have flu, then common are cough, fever, then tiredness and headache and aches and pains, but there is no sneezing. So this chart shows on the left the difference between Delta and Omicron, and also different from these two from common cold and flu. So for contacts, testing is not mandatory for asymptomatic contacts. For asymptomatic family members exposed to COVID patient should monitor health. For suspect cases, following symptoms mean you are a suspect case: fever, cough, headache, sore throat, body ache, loss of taste or smell, or breathlessness. Seek medical hospitalization if oxygen saturation drops 93%, breathlessness or dizziness, fever persists for more than 100 °F for 3 days or more, persistent pain or pressure in chest, mental confusion. These are the indications for hospitalization and or medical consultation. Treatment at a hospital: budesonide meter dose inhaler, dry powder inhaler, only if symptoms persist for 5 or more days. Antibiotics as advised by the doctor. Next slide, please. Rapid case spread, but fewer hospitalization. That's the global pandemic is soaring to new heights pushed by the Omicron variant of SARS-CoV-2. But there is a catch to reading case numbers. On the ground statistics like hospitalization have not yet come close to soaring to record levels. A closer look at countries that have been experiencing the Omicron wave a few weeks shows how the outcomes are playing out differently in cases and hospitalization. The wide gap in cases and hospitalization. United States, though the cases increased by 120%, but hospitalization decreased by 20%. United Kingdom, cases increased by 213%, hospitalization decreased by 64%. In Denmark, from the previous wave peak, cases increased by 328%, hospitalization decreased by 18%. In France, the cases increased by 296%, but hospitalization decreased by 35%. In Italy, cases increased by 399%, but hospitalization decreased by 57%. Delta waves are getting dwarfed. The new waves being pushed by the highly transmissible Omicron variant are dwarfing case numbers seen even during the brutal Delta waves abroad. The outbreak in the US, Italy, and France is currently at its worst ever. In the US, there has been an average of more than 500,000 new cases detected every single day in the past week, a 120% increase from the corresponding figure in the Delta wave in January 2021. In Italy, the latest wave has outstripped Delta peak by 399% as the country is reporting 115,791 new cases every day on average in the past week. In France, which is reporting 180,515 cases a day, has seen a 296% increase from Delta peak. Cases in all these countries are still rising. In two nations, Denmark and the UK, the Omicron wave appears to have peaked, but despite the recent drop in cases, In the UK, cases are 213% higher than the Delta wave peak. Similarly, in Denmark, where cases have started dropping, the current case rate is 328% higher than the previous peak. Hospitalizations are nowhere near Delta waves. What this means? This means that despite case numbers rising, the Omicron variant appears to be causing cases that need considerably fewer hospitalizations than previous variants that have ravaged the world like Delta. And preventing hospitalizations prevents deaths in the longer run. The fewer people get sick enough to be hospitalized, the fewer will die. The target of the pandemic for any country. Next slide, please. Let's look at another important aspect. Third wave limited to big cities, but has started to spread beyond as well. The third COVID wave of COVID-19 is upon India. The 7-day rolling average daily cases had increased every day for the past 10 days from 6,780 to 40,459.95, the highest in September 7. This is the national level, but what do the disaggregated numbers show? Let's examine. Next slide, please. The surge started in the most urban districts a little earlier. It is understandable that current surge is happening in big cities where people arrive from abroad, since the Omicron variant was first detected outside the country. This is confirmed by data. How India Lives has compiled district level cases up to January 5. These districts into 5 categories have been done, and the entirely urban districts, mostly metros and a few capital cities, have rural population shares of less than 20%. This is based on the 2011 census, and the entirely rural districts have less than 20% urban population, with other categories in between at similar 20% interval. Disaggregating cases across categories shows that in the entirely urban district, the 7-day rolling average of new cases was increasing before a consistent surge was seen at the national level. Here, the average increase daily for 16 days up to January 5. In all other categories of district, this had happened for 9 days or 7 days. Then there are outlier districts in rural urban categories. To be sure, even the above categorization hides some district level peculiarities. For instance, in Delhi and Mumbai, which are in the most urban category, the 7-day average had been rising for 21 and 20 days, longer than for the category as a whole. Such outliers are also present in other categories. Of the 125 districts where the average has increased for the last 7 days, only 6 are of the same urban level as Delhi and Mumbai. 17 of them are from largely urban category, that is 20 to 40% rural population, such as Surat in Gujarat, Indore in Madhya Pradesh, and Palghar in Maharashtra. 34 such districts with consistent upward trajectory for a week are also ones where rural population share is over 80%. These include Raigad in Chhattisgarh, Gaya in Bihar, and Kangra in Himachal Pradesh. Next slide, please. Cases are high only in the most urban areas, but spreading to most parts. The two arguments made in the previous slide highlight two things. One, that the current surge is largely led by metros. Two, that a high caseload in the metros does not mean people in other districts should go about their lives without masks and social distancing. Another set of statistics makes this even clearer. The 7-day average of cases in 135 of 707 districts for which data is being compiled by How India Lives was 0 on January 5. In another 354 districts, this average was lower than 10. In only 85 districts was the average above 50. Just 7 districts, Mumbai, Delhi, Kolkata, Thane, Bangalore, Pune, and North 24 Parganas, accounted for 50% of cases by 7-day average. However, the number of districts with 0 cases has decreased rapidly from the last week of December, suggesting that cases are now also reaching districts which were COVID-free. Next slide, please. Testing, vaccinating remains the key. As the first chart shows, the increase in cases in the metros has been rapid, and the caseload in these districts is also high now. Given the infectivity of the Omicron variant, it is important to use existing testing capacity. The best testing capacity utilization in any state is only 79%. This is not in Delhi or Maharashtra, but in Odisha, where every test in the week ending January 5 was 79% of its peak testing. Most states were conducting less than 50% of their peak weekly average of tests in that week. Soon, however, states will feel the pressure to enhance testing capacity. They should stock up and distribute self-administered kits to encourage people to test at home. As previously suggested, it is also important to track symptomatic positivity rates and hospitalization rates and tailor policy responses on the basis of these. Another way in which the impact of this wave can be possibly reduced is by fully vaccinating the entire eligible population. Two-dose vaccination appear to reduce the severity of COVID-19 infection from the Omicron variant. In states like Bihar, West Bengal, Uttar Pradesh, Jharkhand, Punjab, and northeastern states, excluding Assam, some of the most populous states in the country that also have poor health infrastructure, the share of fully vaccinated adults is not even 60%. They need to catch up with other states if they don't want to be overwhelmed by the hospitalizations. Next slide. Now we look at another new aspect of the pandemic. Will India benefit from the two new COVID therapies? As Indian hospitals prepare for a likely surge in admissions of COVID-19 patients, two new antiviral drugs, that is nirmatrelvir and molnupiravir, will expand the arsenal of tools available to doctors. Against the fight against COVID, while India's clinical guidelines on COVID management are yet to endorse the two new antiviral drugs, generic firms are all set to launch one of them in the country. Which drug offers most clinical benefit, whether it is molnupiravir or nirmatrelvir, preventing hospitalization and death? Now, molnupiravir reduces 33% efficacy. This is efficacy in trials for preventing hospitalization and death, while nirmatrelvir has shown 88% efficacy. Recommended usage by US FDA is molnupiravir adults not hospitalized for severe COVID, and then children for nirmatrelvir, children over 12 and adults not recommended for patients having severe kidney or liver damage. Molnupiravir is available through 8 generic companies expected to launch the drug this month, while nirmatrelvir is the generic companies yet to file for regulatory approval. Next slide, please. How do the two new COVID drugs work? Nirmatrelvir, brand name Paxlovid by Pfizer, is a combination of two antiviral drugs that can slow the spread of the infection by blocking the virus from replicating. Paxlovid belongs to a class of drugs known as protease inhibitors, which are commonly used in it to treat HIV/AIDS. In a 5-day treatment course of a total 30 tablets, with 3 tablets taken orally twice a day, molnupiravir by US drug maker Merck is also an antiviral that introduces errors in the SARS-CoV-2 and prevents its replication. Molnupiravir is a 5-day course consisting of 40 tablets with 4 tablets taken orally every 12 hours. Second aspect is what is their efficacy in clinical trials. Nirmatrelvir, when administered within 5 days of the onset of symptom, reduced the risk of hospitalization and death by 88% compared to those who did not receive the drug. It became the first oral antiviral to be approved by the US FDA for the treatment of mild and moderate COVID-19 patients, including children over the age of 12. In case of molnupiravir, the reduction in risk of hospitalization or death was 30% in the trials. The US FDA said the drug is likely to be effective only when administered immediately after the onset of symptoms. Molnupiravir is not recommended for children. Next slide, please. What is the price of these two new drugs? Molnupiravir is priced in the range of 900 rupees to 1600 rupees for a full treatment course, 5-day course of 40 tablets. There is no MRP for nirmatrelvir yet, as Pfizer has struck deals with governments across the world for their bulk sale. The US government alone has made an upfront payment of $1 billion for the purchase of the drug. Next slide. When will these drugs be available in India? 8 Indian drug makers are gearing up to launch molnupiravir in India as part of their voluntary license agreement with the drug maker Merck. The drug is expected to reach the market by end of January. For nirmatrelvir, no Indian generic maker has yet signed an official agreement with Pfizer or has announced a clinical trial, a regulatory requirement to launch the drug locally. Doctors who have been following the trial outcomes of these drugs say that nirmatrelvir is potentially a superior drug than molnupiravir. What are the other treatment options? India's clinical guidelines on COVID-19 management is yet to endorse these two new antiviral drugs. There are no clinically proven drugs to treat mild COVID. For the moderately ill, India recommends the use of inhaled budesonide and asthma drug if symptoms such as cough or fever persist even 5 days after the onset of symptoms. The other recommended drugs are remdesivir, steroids such as methylprednisolone, blood thinners such as heparin, and tocilizumab is recommended for patients in the ICU. Let's look at other data. Next slide, please. This is the latest data about confirmed cases, deaths, tests per million per day, 7-day average test positivity rate percentage, and growth of active cases in all the states of India from top to bottom. You see now confirmed cases 1,41,503 in the last 24 hours, with Maharashtra, West Bengal, Delhi, Tamil Nadu, Karnataka, and Gujarat at the top 5. In terms of deaths, 282 deaths, out of which Kerala 189, Maharashtra 20, West Bengal 15, Delhi 9, and Tamil Nadu 8. Tests per million per day highest are being conducted by Mizoram, Delhi, Pondicherry, Goa, and Jammu Kashmir. But look at the bottom. Nagaland, Himachal, Sikkim, Manipur, West Bengal, Andhra are conducting very low tests per million per day. 7-day average test positivity rate is highest in West Bengal and Goa, 20% and 18%, 16.8%. Mizoram, it is 15%. Maharashtra is 13%. Delhi, 9%. And you find these are the states where Indian average is only 5.3%. Growth of active cases is highest in Dadra and Nagar Haveli, Bihar, Uttar Pradesh, Chhattisgarh, Punjab, and Rajasthan. While Indian average is 24.89%, Bihar is 50%, Uttar Pradesh is 46%, Chhattisgarh is 44%. So active cases are growing very sharply in Bihar, UP, Chhattisgarh, Punjab, and Rajasthan. Next slide, please. Two large states with impending elections, that is Punjab and Uttar Pradesh, have double vaxxed just 1/3 of their population. Both are witnessing a major surge in cases, average growth of active cases at 44% and 47%. 67% of adults in India are double vaxxed now. Current average vaccination speed is 78 lakh per day. Next slide, please. This is a slide which shows you the test positivity rates of all the districts where test positivity rate during the period 1st January to 7th January was more than 10%. And in this slide, there are 31 districts, and you find further districts also. But let's look at them. Andaman Nicobar, 1 district, Nicobar. Arunachal, 3 districts, Longding, Lower Siang, and Namsai. Assam, Kamrup Metro. Bihar is Patna. Chandigarh is Chandigarh. Chhattisgarh is Durg, Korba, and Raigad. In Delhi, Northwest, East, South, West, New Delhi, Central, Shahadra, North, and Northeast, and Southeast, all are showing more than 10%. Goa, it is North Goa and South Goa both, more than 10%. Gujarat, it is Ahmedabad. Haryana, it is Faridabad, Gurgaon, Panchkula, Ambala. In Himachal, it is Lahore and Spiti, Kangra, Kullu, and Bilaspur. All are showing more than 10% positivity rate during the week. Next slide, please. Jharkhand, it is again 3 districts, Latihar, Ranchi, and Kodama. Kerala, it is 1, Tirunantapuram. Madhya Pradesh, it is 1, Ujjain. Maharashtra, it is Mumbai suburban, Mumbai, Thane, Raigad, Palgad, Pune, and Nasik, all showing more than 10%. And if you look at Mumbai suburban, it was 30.67%. Very high positivity rates. Mizoram, entire Mizoram, all the districts are showing more than 10% positivity rates. Nagaland, 1 district, Tuensang. Odisha, Khurda, it is showing more than 10%. Punjab, Patiala, Pathankot, SAS Nagar, and Batinda are showing more than 10%. In Rajasthan, it is Jaipur district, more than 10%. Sikkim, it is North district and West district. In Tamil Nadu, it is Chennai, Thiruvalur, and Ranipet. Uttar Pradesh, it is Gautam Budh Nagar and Ghaziabad, both adjoining Delhi, more than 10%. Next slide, please. Now, West Bengal, look at that. Kolkata, it is 55.33%. 55.3% positive in a week. Howrah, it is 42.39%. Paschim Bardhaman, 28%. 24 Parganas North, it is 24%. Birbhum, 23.3%. 24 Parganas South is 22.47%. Malda, Darjeeling, Hooghly, Purba Bardhaman, Bankura, and Purulia all are showing more than 10% positivity rate during the week, while Indian average is 7.11%. So there are 78 districts now which have shown more than 10% positivity rate during the last 7 days. Very serious situation. 78 districts in the country. Next slide, please. Now, this is the state-wise status of Omicron variant as today morning. You see now 876 cases of in Maharashtra, Delhi 513, Karnataka 333, Rajasthan 291, Kerala 284, and Gujarat 204. Telangana is 123, and Tamil Nadu 121, and Haryana 114. All the states are less than 100 cases per day. Next slide, please. There are 27 states in the country which are showing Omicron now, and the total 3,071 cases, out of which 1,203 have recovered. Next slide, please. This is the position for the week from Southeast Asia region. After declining trend in the number of weekly cases since the end of July 2021, the Southeast Asia region reported an increase in case incidence of 78%, corresponding to over 135,000 new cases. However, the number of new weekly deaths decreased by 9%, with over 2,400 new deaths reported. Half of the countries, that is 5 out of 10, reported weekly increases in the number of new cases of over 10%. After India, the highest increases in the new cases were reported by Bangladesh, 48% increase, and Maldives, a 31% increase. The highest numbers of new cases were reported from India, that is 102,000, with 120% increase. Thailand with 6% increase, and Sri Lanka with 8% increase. The highest number of new deaths continue to be reported from India, that is 2,088 with 8% decrease. Thailand, 140 deaths with 31% decrease, and Sri Lanka, 135 deaths with similar position to the previous week. Next slide. This is the global pandemic graph, and what you see, a sharp, very, very sharp and a very high increase across the world, and contributed mainly by Europe and Americas. Europe is shown in green and Americas are shown in yellow. During the week of 27 December to 2nd January, following a gradual increase since October, the global number of new cases increased sharply by 71% as compared to the previous week, while the number of new deaths decreased by 10%. This corresponds to just over 9.5 million new cases and over 41,000 new deaths reported during the past week. As of 2nd January, the total number of 289 million cases and just over 5.4 million deaths were reported globally. All regions reported an increase in the incidence of weekly cases, with the region of the Americas reporting the largest increase, that is 100%, followed by Southeast Asia region, 78%, European region, 65%, Eastern Mediterranean region, 40% increase, Western Pacific, 38%, and the African region, 7%. The African region was the only region to report a weekly increase in the number of new deaths, that is 22%. All of the regions reported a decrease in the incidence of deaths, including the Americas, 18% decrease, Western Pacific, 10% decrease, Southeast Asia, 9% decrease, Eastern Mediterranean, 7% decrease, and the European region, 6% decrease. Next slide, please. This is the same data which I just told you, and you find the maximum contribution of new cases in the last 7 days was by Europe, 57%, Americas, 34%, Western Pacific, 3%, Africa, 3%, and Southeast Asia, 1%. Next slide, please. This is the graph of the entire pandemic in Americas, Europe, Southeast Asia, Eastern Mediterranean, Western Pacific, and Africa. And what you find, America's sharp increase, sharpest, highest increase. Europe, very high increase. And Africa, very high increase. Western Pacific, a very high increase, and it is increasing faster. Southeast Asia just started, and now you find 6 countries in this slide and 6 more countries in the next slide, the top 12 countries in the world with highest number of confirmed cases. India is at number 2 position, USA is number 1 position, and you still rising. India has just started rising. Brazil again started rising. UK is rising very sharply. France is rising very sharply. Russian Federation had faced, now it is going down. Next slide, please. Turkey is going up. Germany is again going up. Italy is going up sharply. Spain going very sharply up. Iran is going down. Argentina is going up very sharply. Next slide, please. This is the table showing cases newly reported in last 7 days. All the countries are ranked from one to top to bottom. So the global cases newly reported as on date today were in the last 7 days, what were 1,33 lakh, out of which 40,27,000 were from USA, out of which 6,92,000 were in the last 24 hours. France reported 14,19,000 cases in a week, with 2,58,000 during the last 24 hours. UK reported 12,67,000 cases with 1,79,000 last 24 hours. Italy reported 9,94,000 and 2,19,000 last 24 hours. And Spain, India, Argentina, Turkey, Australia, Canada are there in the top 10 in the world in terms of cases in the last 7 days. So the pandemic is very, very much active all across the world. Next slide, please. This is the ranking of countries according to deaths newly reported in the last 7 days, and which are the top 10. USA, Russian Federation, Poland, India, Germany, Vietnam, France, Italy, Ukraine, and United Kingdom are in the top 10. And you can see how big is the number, and it is increasing. Next slide, please. This is the map of the world with COVID-19 cases per 1 lakh population reported from the countries. And darker brown is the highest number. And where is that color? It is across Europe, and now it has gone to Australia, it has gone to Africa, it has gone to Americas, it has also gone to South America. So you're seeing dark brown colored shades, very high COVID cases per 1 lakh population. Density, very high reporting. Next slide, please. This is the COVID-19 deaths per 1 lakh population, and darkest blue is the most concentrated deaths, highest deaths per 1 lakh population. And that is in Europe, the Central Europe. Next slide, please. Another interesting fact which needs to be shared with the audience today is the COVID-19 mortality in India. National Survey Data and Health Facility Deaths. The article published yesterday in the journal Science by Prabhat Jha and his colleagues. The Center for Global Health Research, Unity Health Toronto, and Dalla Lana School of Public Health, University of Toronto, Toronto. It says the Indian national COVID-19 death totals remain undetermined. Using an independent nationally representative survey of 0.14 million adults, we compared COVID mortality during the 2020 and 2021 viral waves to expected all-cause mortality. COVID constituted 29% of deaths from June 20 to July 21, corresponding to 3.2 million deaths, of which 2.7 million occurred in April-July 21, when COVID doubled all-cause mortality. A sub-survey of 57,000 adults showed similar temporal increases in mortality, with COVID and non-COVID deaths peaking similarly. Two government data sources found that when compared to pre-pandemic periods, all-cause mortality was 27% higher on 0.2 million health facilities and 26% higher in civil registration deaths in 10 states. Both increases occurred mostly in 2021. The analysis finds that India's cumulative COVID-19 deaths by September 21 was 6 to 7 times higher than reported officially. Imagine the catastrophe of deaths that India has faced. Deaths are not available in the official data records, and the problem is of the size of 6 to 7 times. That is the latest scientific evidence that has been published in the very reputed journal Science. Next slide, please. Attention is the rarest and purest form of generosity. I am grateful for your generosity as you have given attention to the presentation shared just now. Thank you so much.
Thank you very much, sir, for your lovely presentations. So this is a time for question answer. I must hope that people may ask questions, as many as they can. So who is asking first?
Dr. Shyam Pingle is there, Dr. Rotithor, Dr. Shiva, Dr. Kamla Partyal, Dr. Tyagaraju are in the panel at the moment. Anyone can unmute and talk and come. I welcome comments and questions if any.
Dr. Thank you for a wonderful presentation. I have one question, Dr. Considering the huge surge of COVID infections, which looks to be more like Omicron only, I think, I just wanted to know if a person is using self-testing kits, how to get it registered so that we are able to isolate the patient and it comes in the register also.
Well, the currently licensed self-testing kits in India, they have an application. The person has to upload the results on the application and that gets linked with the ICMR portal. So it gets registered in the system. The district authorities are sounded and accordingly they take follow-up action.
Okay. Thank you, Doctor. Thank you.
Welcome. Dr. Shyam Pingle has unmuted.
Oh, I have no questions and interesting presentation and tough time ahead.
Yes.
For a few weeks at least. Only thing is, how far and what is the relevance of contact tracing in this coming scenario?
Very relevant question. Actually, that is the toughest.
Numbers are going to be so high.
In fact, it is stretching resources beyond the available results and how much we gain, especially in Mumbai suburban and Kolkata and Delhi. The kind of positivity rates that are being reported districts after districts, contact tracing has its limited role to play.
Any other questions?
Dr. Rotithor, want to say something? Or Dr. Seva?
Great presentation, sir.
Yeah.
Thank you.
Okay. Dr. Tyagaraju or Dr. Seva is wants to say. Yes.
No, Rajiv, as usual, excellent presentation and very, very informative. Thank you very much.
Welcome. Thank you so much. Dr. Divyansha has raised his hands.
Good evening, sir. Can you hear me?
Yes, of course.
Yeah, sir, one question regarding this contact tracing. Now, all the people are having the double vaccinated, most of those.
Yes.
So, in case of the home positive case, do other fully vaccinated people require the quarantine, or they can come out of the house as they are at low risk?
Well, if you read the current national guidelines for home isolation, the caregiver for COVID positive person should be a double vaccinated person, preferably. And even then also he should use the mask, preferably N95 mask. And if he has to move out, he has to follow. That is irrespective of requirement of caregiving or not caregiving. One has to understand that vaccine will not prevent infection. Vaccine was not intended to prevent infection also. Vaccine had a limited role to play only for limiting the complications, that is hospitalization, deaths. That was the purpose of the vaccine. And that it seems to be meeting in the cases record that have come even with Omicron. So the bottom line is the person who is fully vaccinated in the home should be the caregiver for the person who is found positive. And especially if the person is unvaccinated, unfortunately, if he's positive, that is the major situation which needs to be tackled. And people who are fully vaccinated from Monday, that is from day after tomorrow, if they are health workers or frontline workers, they must get a booster dose or a precautionary dose, as it's called.
Thank you, sir. I'll appreciate comments from other panelists on this question. Basically, this is pertaining to the industries where the factories where work from home is not possible. So if a worker is doubly immunized and his spouse or parents are infected, whether they can be allowed to come to office or not, or the workplace or not. Comments from other stalwarts also, please.
Dr. Shampingle, would you like to say anything on this? With Dr. Devansha's question? Or Dr. Sriniket would like to comment? Because he is, yes, Dr. Shampingle wants to say. Yes.
Divyang, could you repeat your question?
So the question is that in factories or the continuous process industries where work from home is not possible, the workmen can be allowed to attend the workplace if they are doubly immunized in the case where they have the positive case in their household.
I think by proper use of mask and other COVID appropriate behavior, we will have to allow them. And otherwise, we will have to close down again, because the numbers, the rate at which numbers are increasing, if the industry has to run, we will have to make these adjustments.
Right, sir.
Dr. Divyang, I would like to share with you the situation in Lady Harding Medical College in New Delhi. Now, all the health workers, if they have a family member positive at home, they have to be continuing to work in the hospital and wear N95 mask and face shield or goggles. And they are actually working in one of the very heavily attended hospital of Government of India in New Delhi. And that is the official condition. And if you had heard the World Health Organization, they also were talking about quarantine flexibility. One has to see the level of infection in the community and transmission in the community. One has to ensure that the services continue with precautions.
Okay. Thank you, sir.
Divya, the other possibility is the worker get a RT-PCR done so that you are on the safer side.
Right, sir. But then it is a challenge how frequently it should be done.
I think every 7 days.
Okay.
Because see, if he is exposed, after 7 days, exposure goes off.
Right. That's also good suggestion, sir. Yeah.
Any other questions from anybody? Should we conclude then?
Yes, well, you could think of, there is a question in the Q&A box. If the illness is mild, should there be any restriction? Well, interesting question. If the illness is mild, restriction is as per the national guideline, that is isolation. And accordingly, get yourself tested and follow the national guideline for mild cases as per the National Guideline Institute this week. And I've also presented in my presentation.
This question was from Dr. Bimal Kumar Singh.
Yes.
Yeah. So I do not expect now any questions, so better we should conclude now.
Yes.
Sir, I would like to extend my sincere thanks and heartfelt gratitude to both the eminent speakers, that is Dr. Rajesh Pasricha and Dr. Rajiv Kumar Jain, for excellent session today. Humbly, thanks to all participants for making these sessions more meaningful. Thanks to organizers, AUSD Delhi, a branch, for organizing such a beautiful knowledge sharing session. Last but not the least, thanks to organizer again for giving me opportunity to be a moderator, and thanks to Mr. Basist and all support system for all assistance required for moderation. Thank you everyone. Have a very nice weekend.
And before we close, one announcement that this entire recording will be available on YouTube channel, Enoch DigiConnect webinar channel shortly, and you could watch a recording of entire presentation by both the speakers. And you should also subscribe to the channel so that you are notified by YouTube of new videos being uploaded. There are at the moment 140 videos available for all occupational and environmental health practitioners in the country and in the world. So it's worthwhile listening to the hearing again. Dr. Shiva, want to say something?
No, I just wanted to tell people that Molnupiravir is available now in India.
Yes, it is. It is.
Yeah, and the dosage is 4 tablets twice a day.
Yes, true. But you must have heard the DGICMR telling that it should not be used, or it should be used with caution. It should be used with the riders, because the studies that have led to the situation should be read first by all the practitioners, and one should hear that cautionary note from ICMR DG. So one has to understand that this is still emergency licensing, and not for over the counter, or it's not be used as a routine drug by all the people with mild COVID-19. Especially, it should be reserved for people who are unvaccinated, have mild COVID, and have comorbidities. That should be the indication for using COVID-19 only in adults, not at all for children below 18 years.
The problem is,
yes, Dr.
the problem is US FDA gives permission, CDC gives permission, and we give permission. They reduce the quarantine period, we reduce the quarantine period. You should have some similar studies, right?
I agree. In fact, that is the dynamic situation, and I believe each country will have its own reasons for reducing the quarantine period as well as isolation period.
Absolutely.
That is true in any infectious disease for that matter. Absolutely. And there cannot be hard and fast rule, a fixed period of isolation or fixed period of quarantine periods. It depends on the situation and the evolution of the infection cycle.
Absolutely.
I think we can close now and discussion can go on.
Sir, thank you, sir.
Thank you, sir. Thank you, sir. Bye, sir. Bye, sir.